Thank you very much, Rajmi, for that kind introduction. I'm happy to be here, happy and honored to be here, to be speaking on my favorite topic, endocrine pathology. It's also a privilege to be here with Herb Chen, or internationally known endocrine surgeon, who will be presenting his talk and a lot of the surgical and clinical aspects of some endocrine lesions, especially in the thyroid. So what I'll do in this first talk, no disclosures, we'll talk about multiple endocrine neoplasias, mainly from the perspective of the pathologist in terms of differential diagnosis and other lesions that we see, things that some of the entities could be confused with. We'll spend a fair amount of time on this. We'll next talk about Carney's complex, from Dr. Aidan Carney, that describes one of the many things that he's described over the years. And then finish up with brief statements in terms of endocrine pathology as they pertain to von Hippel-Lindau and neurofibromatosis. When you think of the endocrine system overall, we're looking at really quite dispersed and quite varied lesions, ranging, if we start from the top, the adrenal medulla, thyroid C cells that Herb will be talking a lot about, parathyroid, pancreatic islets, paraganglia, lots of endocrine cells and tumors in the GI tract, anterior pituitary, skin, specifically Merkel cells as the main example, and then endocrine cells in the lung. And as you know, a lot of these are characterized by having neuroendocrine features, histologically, and having secretory granules expressing proteins such as chromogranins and synaptophysin that we use diagnostically. So it's quite a wide, diverse system. And on the bottom of the slide, we can see that there are other routine systems such as prostate and other glands in which one does have endocrine cells, and rarely one can get endocrine tumors arising from these different tissues. So we'll start out with MEN1. MEN1 gene, as you know, was cloned quite a few years ago. It's located on chromosome 11, and generally it's thought to be a tumor suppressor gene, and then the protein product menin is something that we can look for immunohistochemically if the need arises in diagnostic pathology. In MEN1, we have lesions that are really fairly common, such as parathyroid lesions, hyperplasias, and adenomas that one sees commonly here. One sees lesions in the pituitary, anterior pituitary, and historically prolactinomas were the most common. And then within the GI tract, we have lesions such as gastrinomas, and we're not highlighting, but a lot of these tumors are benign, and then lesions like gastrinomas, they're usually malignant tumors when they're presenting in the duodenum or within the pancreas in some cases. Insulinomas that are commonly benign lesions, as we look at these under the microscope in surgical pathology. And then there are non-functioning tumors such as pancreatic polypeptide producing tumors that are part of the MEN1. In terms of other lesions that one sees with MEN1, thymic carcinoids are pretty uncommon, only a small percentage, as well as bronchial carcinoids can be linked with MEN1. Since they're so uncommon, when we make a diagnosis of a carcinoid tumor from the thymus or the bronchus, we rarely think that these may be an MEN associated thing, but they can be in a small percentage of cases. Within the adrenal cortex, we usually think of the adrenal and the medulla as part of MEN2, as we'll discuss. But occasionally we have adrenal cortical tumors that are either non-functioning commonly or sometimes functioning. And for diagnostic purposes in pathology, most of these are usually benign. There are rare lesions that are malignant as far as adrenal cortical tumors associated with multiple endocrine neoplasia type 1. And then there are lesions that are not part of the typical endocrine system, angiomas of the face, lipomas, leiomyomas. Leiomyomas were uncovered when the MEN1 gene was cloned, and the individuals at the NIH started looking at this very closely and discovered that there were leiomyomas, especially in the esophagus and in the stomach of some of these patients, and other rare lesions such as ependymomas. So what do we see in pathology? This is sort of a historic slide because we rarely get 4 glands to examine today. But certainly if one has an adenoma, as we know, the one gland is going to be quite large, as one sees in the right upper corner here, and the other glands are going to be relatively normal in size. As Herb Kent will be telling us, if we were talking about parathyroids, the presence or development of tests such as the intraoperative parathyroid hormone has really made a major difference in the way surgeons approach this, and really has made the challenge less so for the pathologist today. Because we're usually looking at one gland, and within a half an hour or so, the surgeon can tell if the parathyroid hormone levels have gone down significantly, and he or she can confirm that they're dealing with an adenoma. And oftentimes a frozen section may not even be necessary today to make this diagnosis. So parathyroid adenomas would be seen, and then more commonly parathyroid hyperplasias in these patients. How can we tell the difference in terms of looking under the microscope when we have a large parathyroid? The rim of normal that we see on the upper left-hand side of the screen, it would be a major clue that we're dealing with a parathyroid adenoma. So seeing cells admixed with the adipose tissue, which are usually a little smaller than the cells that within the adenoma, would be very helpful diagnostically in confirming that diagnosis. Hyperplasia, of course, all 4 glands are usually involved, especially with primary hyperplasia. In terms of thinking about differential diagnoses, another condition when we have a parathyroid that may be genetically inherited to is the so-called parathyroid glands from hyperparathyroidism jaw tumor syndrome. These individuals usually present with primary hyperparathyroidism as well. Sometimes early on, but sometimes later, they may have fibromas of the jaw developing as a feature, cysts in the kidneys. Then there is usually, in terms of thinking about this rare condition, they often have a high incidence of parathyroid carcinomas. So about 20% of patients with the syndrome that have parathyroid abnormalities would have carcinomas. So our differential, usually you should be thinking more about malignancy in these cases, whereas MEN1, they're usually benign lesions in almost all cases. The gene for HPRT2 was mapped to chromosome 1 some years ago, and the protein product is parafibromin that's being produced on this gene. And one of the really nice things in terms of helping us in diagnostic pathology is parafibromin can be used now as a marker if we have a difficult case of trying to sort out parathyroid adenoma from a parathyroid carcinoma. So parafibromin protein by immunohistochemistry is extremely helpful in doing this. The sensitivity is only about 75%, but this added to the conventional features that we use to sort this out can be very useful. Okay, this gene is thought to be a tumor suppressor gene, and in one of the early studies it was seen the expression of this was in 10 of the 15 patients that they had parathyroid abnormalities. Now we're back to MEN again in terms of looking at the pathology of MEN1. Pituitary tumors can be seen in patients with MEN1. It is less common than parathyroid adenomas, hyperplasia, but patients do have these such. And if you're in the pathology lab and you have a pituitary tumor, in terms of doing the frozen section, you can see the anterior pituitary on the right side of the screen showing the adenoma that's discrete from the other areas, and the posterior pituitary is on the left side. Today, it's usually the neuropathologists that are looking at pituitary tumors in terms of frozen section or final diagnosis. So many of us in general surgical pathology do not get to see these as often. Histologically, one can apply traditional stains that don't have to be sophisticated immunohistochemical stains. But the reticulin stain on the right, on the left side, one sees normal anterior pituitary with little nests of cells, and pituitary adenomas usually have disruption of the reticulin as is seen on the left side of the screen. As you know, pituitary carcinomas are extremely rare, so one usually doesn't have this in the differential diagnosis as such. And just to make this broader, it's been observed by some reports in the literature now that this reticulin stain, or old-fashioned reticulin, is also useful for separating adrenal cortical adenomas from carcinomas. So another practical application of using a historical stain, such as the reticulin stain in those cases. Pituitary tumors, one usually has prolactinomas as the most common, historically in the series of Dr. Kovac and others that really compiled a lot of these. These are pretty common in terms of surgically removed tumors. But for the past 10, 15 years, the use of drugs to treat prolactinomas rather than surgical excision has really decreased the percentage of cases of prolactin-producing pituitary adenomas that are operating on. Then secondarily, and even higher percentage today, are the growth hormone tumors and the ACTH tumors and the others. They're relatively rare, except for these gonadotroph and null cell adenomas that are relatively common. So these are non-functioning tumors that really constitute a large part of pituitary tumors. And if you're doing work with pituitary adenomas, it's important to distinguish between the functioning tumors and the ACTH silent tumors, which stain for ACTH, very mysterious, but does not express or secrete, and patients do not have Cushing's disease because of a silent ACTH tumor. And the answer as to why that's happening is still unknown. This would just be an example of a growth hormone producing pituitary tumor. And notice one thing in endocrine pathology that one can say across the board is that pleomorphism, nuclear pleomorphism, is a pretty common and constant feature. So if one's looking at lesions in the liver or the GI tract, for example, pleomorphism of the nuclei, as one sees here, would be worrisome in terms of malignancy, but that's not the case whether it's a pituitary lesion or a lesion occurring in the thyroid gland or adrenal cortex. And then today, of course, one uses immunostaining to diagnose pituitary adenomas, in this case, growth hormone staining. And this is really quite, almost indispensable for the current classification of pituitary adenomas. Okay. As far as multiple endocrine neoplasia type 1 and pancreatic tumors, one can have pancreatic tumors which can be benign or malignant. As we indicated, gastrinomas, if they're occurring, whether they're occurring in the pancreas or more commonly in the duodenum, are commonly malignant lesions, even if they're extremely small. This would be a higher view of a pancreatic endocrine tumor, showing the cells compressed between collagen. And one of the questions we could raise without having a Congo red stain or another stain for amyloid is whether or not there is amyloid present in the stroma of the tissues. Another generalization about endocrine amyloid that we can make, and it will come back to the thyroid, but endocrine amyloid is really morphologically and with staining such as Congo red looks the same. At the electron microscope levels, it looks the same, but the molecular composition would be very different. So amyloid, if one has an insulin-producing tumor, which is not uncommonly associated with amyloid, one usually has a precursor of insulin in those cases, while in the thyroid gland, one has a precursor of calcitonin contributing to the amyloid material that you see. The adrenal cortex, the tumors, as we said before, are usually benign. You can see the normal adrenal cortex present on the upper left-hand side of the screen, and the adenoma that's in the center of this lesion. So grossly, where there's no necrosis, if the tumors are less than, say, 3 centimeters, we would rarely be thinking of a carcinoma. It's usually an adenoma that would be a common lesion in patients with adrenal cortical disease associated with multiple endocrine neoplasia type 1. Histologically, we can look at the slides, and in the absence of mitosis and other features, we can readily make a diagnosis of cortical adenoma, and with the history, we can link these in small percentage of cases with multiple endocrine neoplasia type 1. Now, multiple endocrine neoplasia type 2A is somewhat different from one in that the thyroid is involved, and it's usually C cells of the thyroid that's involved with this. Pheochromocytomas occur, but in only half of the patients that have this disease. And then parathyroid tumors occur in a smaller percentage of patients than in MEN1. Then the familial medullary thyroid carcinoma that we'll not mention very much except now. They have thyroid medullary or C cell disease, but do not have involvement of the adrenal medulla or other lesion, or the parathyroid or any other lesion, as in MEN2A. And as Dr. Shen will really talk about these MEN in more detail in his talk, this is an area in which a lot of advances in terms of understanding the genetics is really important, and this combines with the morphology that we as pathologists see in confirming or making the diagnosis in some cases. So pheochromocytomas are only in 50% of the patients, but most of these patients have medullary, 100% have medullary thyroid carcinoma. MEN2B is generally thought to be a more aggressive disease than the MEN1. Medullary thyroid carcinoma, again, in 100% of the patients. Pheochromocytomas, roughly in half of the patients, as such as with the case of MEN2A. And the distinction, both, I was very fortunate that at the University of Michigan in the 80s and 90s when I was there, and then at Mayo Clinic they had a large series of patients with both MEN2A and 2B. So we really saw quite a spectrum of patients with these diseases. And then Marfanoid habitus is certainly one of the things we learn in medical school that's very characteristic of a patient with MEN2B, and one can separate this readily in terms of the physical exam from MEN2A. And then neuromas, as Dr. Carney described many years ago, starting from the tongue but all the way down to the GI tract would be a common finding in patients with MEN2B. As pathologists, the lesion that we see most commonly associated with this would be the medullary thyroid carcinoma hyperplasia spectrum. So here we're looking at a C cell in the middle of the screen here. That clear cell, my pointer doesn't seem to work, but shows a cell that has clear cytoplasm. And the thing in terms of practical diagnostic pathology is that if you're looking for C cells, they're very, very hard to find on H&E. So one routinely has to do immunostains to really be sure that you're dealing with C cell abnormalities, especially if you're working up a young patient. So one does immunostains, and with calcitonin antibodies or chromogranin A antibodies, one can see the brown staining here indicating that this is C cells. How can we help the surgeon in sorting these out? One critical question that always comes up is, are we dealing with C cell hyperplasia, or are we dealing with a small tumor of C cells? If we have C cell hyperplasia, the cells are confined to the follicles. Even though they're called parafollicular, historically, they're really intrafollicular cells, as we see in many areas of the photograph. And if we had that bundle in the center of the view, and that's a microcarcinoma that has broken through the basement membrane. So distinguishing C cell hyperplasia from early carcinoma is important. What do we mean by early carcinomas? These are often called microcarcinomas. That is, they're 1 centimeter or less in size. Why is it important to sort out microcarcinomas from routine medullary thyroid carcinomas? One critical factor is that if one has a microcarcinoma, the probabilities of metastasizing the lymph node is extremely small. So with microcarcinomas, the lymph nodes are usually going to be negative, whereas if you have a larger tumor, the lymph nodes are more likely to be involved. And as you'll hear later on, once you have tumor outside of the thyroid gland into lymph nodes, then the patient is essentially cannot be cured and may have many recurrences over a long period of time as far as morbidity. So we pathologists can really look at the slides, decide by immunostaining if there's C-cell hyperplasia, and that links to MEN2A or 2B. And just remember that one can have MEN or C-cell hyperplasia in other circumstances, so it's not an absolute link. The absolute link in terms of diagnosing MEN2A and 2B is to really take some blood, look for the RET mutation, specific types of RET mutations in these patients. So we as pathologists are helped a great deal in terms of sorting out different reasons for hyperplasia by having a blood test done on the patient or his or her relatives. And one of the things we always stress to our pathology residents is how to approach the thyroid gland in looking for C-cell hyperplasia. You notice here in terms of these slices of thyroid that most of the dark circles are really present in the mid to upper portion of the thyroid. So we always advise that you should really slice the thyroid, count the slices from the top going all the way down. And you expect to find C-cell hyperplasia and to do the immunostains on the slices that are positive higher up. And this is usually confirmed. This was from a diagram by Drs. Wolf and Tashan, who really did this and published in the New England Journal of Medicine many years ago. And if you measure the levels of calcitonin from the tissues, it's shown on the right that they're usually higher in general, also on that side. How does this process occur? And we can learn about the mechanism of disease development by following the C cells. The black circles sort of tell us that we are dealing with C cells here. So within a patient with genetic or familial MEN2A, 2B, one has normal C cells, occasional C cells, same thing in sporadic cases. But if it's familial and it's driven by these mutations, one has enlargement of the cells first, hyperplasia of some of the cells, diffuse hyperplasia, and they break out of the basement membrane, and one goes on to develop carcinomas of the C-cell origin in the thyroid. And as we emphasized before, just having hyperplasia sort of confirms the RET proto-oncogene mutation that was found in the blood. But if you have a carcinoma, this is where we as pathologists can really sort out, is it a microcarcinoma or is it a larger carcinoma that's capable of metastasizing to lymph nodes? These would be examples of cytology for medullary thyroid carcinoma. At the University of Wisconsin in Madison, we have a great system there that Chen was one of the individuals that set up where you can do the cytology examination, and that's done with the cytopathologists and the endocrinologist and the surgeon. And then right away you can get a diagnosis made, and after that the surgery can be planned for these individuals within a period of time that fits with their schedules too. So a rapid turnover of making a diagnosis and then acting on the diagnosis that's made with the team that's working on this. And this shows cytology of medullary thyroid carcinoma. To a pathologist in the audience, or cytopathologist, you'd say, gee, those cells look as if they could be plasma cells. And it's one of the things to remember in the differential diagnosis, that the plasmacytoid appearance of the C cells in F and A can be somewhat misleading, and one sees, one has to make that distinction, especially with sporadic disease, when you do not have a history of multiple endocrine neoplasia. The other thing for pathologists to be aware of in looking at medullary thyroid carcinoma is that they can look like a regular follicular neoplasm. So here's the circumscribed. We usually think of medullary thyroid carcinoma as being infiltrated. Here's a case that was actually circumscribed and looked as if it could be a follicular adenoma or a follicular carcinoma. This case was seen by one of my colleagues when I was at Mayo. And as you know, historically things have been done on quick frozens at Mayo, and then the slides are looked at the following day on H&E to confirm the diagnosis. And the rapid diagnosis that was made here was that this was a follicular adenoma because it was circumscribed and it was not infiltrated. When it looked that way under the microscope with a quick toluene and blue stain. And then when pathologists looked at the slide the following day and brought it around to the endocrine pathologist, they quickly realized that this was a medullary thyroid carcinoma. Hence, that was the correct diagnosis to make. The diagnosis was changed, and that triggered, it was a young patient, so that triggered the evaluation for the possibility of multiple endocrine neoplasia type 2A or 2B one has a tissue diagnosis. What do these look like under the microscope? Here is the medullary thyroid carcinoma, and as it was described way back in 1959, there are spindle and epithelioid cells. So seeing both types of cells can be very helpful in making the diagnosis. But that's not always the case, and these can be rather difficult to diagnose histologically. Here are the cells, and then we have the pink material in the center, and yes, you can see this is amyloid that's present after if you do a Congo red stain. And as we said with the amyloid here, it's endocrine amyloid, but different from the endocrine amyloid in the pancreas, or different from endocrine amyloid that one sees occasionally in parathyroid. This would be procalcitonin that gives that amyloid configuration to this. And then the cells are pleomorphic, as one has commonly with medullary thyroid carcinomas. And just to take it a step further, you do your Congo red stain, and you see the apple core birefringence that's helpful in the diagnosis of medullary thyroid carcinoma. Or something that's done less commonly today, if you look at the EM, you see the fibrils of amyloid. Again, that's diagnostic. And at this level, whether this is from a patient with Alzheimer's or a patient with lambda-like chain disease, the amyloids morphologically look similar. So it's really the molecular characterization that is extremely useful and helpful today in making the diagnosis. And of course, we do routine stains if one's dealing with a medullary thyroid carcinoma. Many markers are positive. The critical ones, chromogranin, synaptophysin, calcitonin, are positive, and thyroglobulin would be negative in these cases. From time to time, someone asks, is there ever a case in which one has mixtures of follicular cells and C cells as one tumor? And that's extremely rare. There are one or two cases in the literature, but usually they're quite separable into two different entities. And this would be the typical immunostaining, where keratins would be positive and chromogranin A would be positive to help confirm the diagnosis of the invasive disease or early on C-cell hyperplasia. Calcitonin also positive, and thyroid transcription factor 1 is also positive in patients with medullary thyroid carcinoma and C-cell disease. If you're looking at the philosophical side of pathology, this is rather intriguing because the old literature would suggest that these C cells are from the ultimobranchial bodies that are located in the neck, prominent in some other animal species, and that they're not really like follicular cells. Nevertheless, they express TTF1, and that's very useful in making the diagnosis. But we shouldn't be just satisfied by looking at the H&E, because medullary thyroid carcinoma could be one of the great imitators of thyroid cancers. On the right-hand side of the screen, if you looked at the slide, a section of H&E quickly, you would say, oh, papillary carcinoma, move on to the next case. But this is actually a medullary thyroid carcinoma imitating a papillary carcinoma with fibrovascular cores and papillae. So one has to be careful. Just a Heritable cell neoplasm, whether it's benign or malignant, depending on mutation of vessels. But this, again, would be another imitator from a medullary thyroid carcinoma. So they can really look like different lesions. It reminds us of melanomas that we see in terms of being a great imitator, and this would be the great imitator within the thyroid. I'll not dwell on this very much, but if one has MEN2A and 2B, and Herb Chen will probably talk about this in greater detail, one can really intervene in these patients a lot earlier, by just a few years of age, rather than later on, and often find either C-cell hyperplasia or early medullary thyroid carcinomas after the blood tests that as positive. We'll switch gears briefly to the adrenal. Remember that in MEN2A and 2B, about 50% of the adrenals are involved. And here the pathologist can also help in making a diagnosis of familial disease. Because in the typical pheochromocytoma, one usually has just one nodule that's positive, that looks like a tumor, whereas in the familial disease, both glands are going to be involved. They're going to be younger patients, and one sees multiple nodules. One of the questions that was raised many years ago is that how do you separate nodular hyperplasia of the medulla from the pheochromocytoma? And someone suggested in the literature that if you had a tumor lesion over 1 centimeter, that was probably a tumor and the others were not. And that has not held up with molecular analysis of these lesions for clonality. So even some of the smaller nodules, as we see here, would be early pheochromocytomas. So one has medullary hyperplasia, just as we have with C-cell hyperplasia going on to tumors. One has medullary hyperplasia, which we see in both glands, going on to the development of tumor. And if the patient is not diagnosed with MEN2A or 2B, if medullary hasn't developed as it doesn't in rare cases early on, one pathologist can certainly help the clinician by suspecting that there's medullary hyperplasia in these glands and making that diagnosis, or suggesting that diagnosis, and then that can be confirmed with a molecular test. Histologically, pheochromocytomas are relatively easy to diagnose. We have the cells in the medulla of the gland, and we have the so-called cell ball-end or cell nesting pattern, and again, positivity for chromogranin and synaptophysin. One of the embarrassing things for pathologists and endocrine pathologists that's even continuing in 2013 is that we really have a great deal of difficulty sorting out benign pheochromocytomas from malignant pheochromocytomas. So in 1950, the individuals that were starting fields at that time said that you can't make a diagnosis of a malignant pheo unless it extends outside of the adrenal glands, and even lymph nodes close to the adrenal would not necessarily be malignant pheochromocytoma. And we've had almost 100 years to really work on this, and we're still perplexed in terms of not being able to make a diagnosis of malignant pheo. So we're still very cautious and do not want to overdiagnose pheos because they're such slow-growing neoplasms. They take a long time to metastasize in many cases. The MEN2B may be an exception in that those tumors are usually more aggressive, but it's still a major area of investigation in pathology to sort this out. The MEN2 gene is on chromosome 10, and RET mutations that we alluded to before, one has different RET mutations, but there is a beautiful correlation between the phenotype and the genotype in terms of MEN2A and 2B, and Dr. Chen will elaborate on this more, but you can see that if one has MEN2A, codon 634 is the most common area that's mutated, whereas MEN2B, codon 918, that one sees the RET mutation. So if you see that mutation, you don't know, you haven't seen the patient as yet, just the tube in the clinical lab, and if you have these mutations, that's certainly one of the probabilities of, that you'll find in working on the patient. How useful is the RET mutation as a diagnostic tool? Not very in general setting, because in routine sporadic medullary thyroid carcinomas, patients can have RET mutations. In this series, about 20% of patients had these. RET in pheochromocytomas in patients with sporadic tumors, a small percentage of these patients can have RET mutations. And in this particular study in the parathyroid, these were extremely rare. But medullary certainly can be involved with this in sporadic cases. We'll shift gears slightly in looking at one of the many things that Dr. Carney at the Mayo Clinic described. This is Dr. Carney. I think he's probably in his mid-80s now, and he still has that gung-ho enthusiasm, still comes to the office, into his lab, doesn't do diagnostic pathology anymore, but does research in all the syndromes and other things that he's described over the years. and continues to follow up these patients and describe new entities. If you keep up with some of the diagnostic pathology journals, such as American Journal of Surgical Pathology, he usually publishes 1 or 2 articles a year describing some new entity or variants of these things that he's described before. So Carney's complex was there were lots of case reports in the literature, and what he did very meticulously, persistently, was to gather those cases plus the ones that he had acquired at Mayo and put these together and then describe these from the just descriptive initial studies to today, where there are actually molecular studies and animal models indicating that Carney's complex is really a very broad spectrum of lesions involved. Patients have myxomas. These are in the heart commonly, and that's really one of the life-threatening that they can have these lesions in the breast. They have nevi, and that one can see on physical exam. And then the endocrine tumor, as far as the endocrine pathology, one sees these in the adrenals, hyperplasia/tumors, testes, and pituitary of the patient. And then they have other lesions such as the melanoma schwannomas that are seen in these individuals that are often benign lesions. So it's an autosomal dominant trait, as in the MEN2A and 2B that we've been talking about before. A lot of patients probably have mutations that, according to the geneticist, rather than de novo mutations, rather than having inherited this. One of the lesions that we pathologists should be concerned about is the adrenal involvement with this. So these patients usually have Cushing's. It's usually a very low level of Cushing's that the individuals have. And then when the adrenal gland is taken out, if you're not thinking of this entity, which is extremely rare, of course, then you're not going to make the diagnosis right away. So they have nodules in the adrenals. They're distinct nodules, as we'll see shortly. And then they may have some other changes that will give a clue. If you look at the adrenal, or this is the X-ray of this, and the adrenal on the left side here shows a small gland. So the glands are not very large. They're not as big as a typical adenomas. They're often hyperplastic nodules early on and early adenomas in these patients. So it may not be as obvious radiologically. When the adrenals are taken out, there's usually bilateral resection because of bilateral involvement. You see the black nodules that's present on the gland in both cases. And certainly metastatic melanoma would be one of the things that one would consider in terms of this. There is some so-called black adenomas of the adrenal cortex that one has, and that would also be in the differential diagnosis. But they're very distinct and very uncommon lesions, so one doesn't consider this very often in the differential diagnosis. And here are the nodules, those eosinophilic nodules that one has within the adrenal. Notice that they're compressing the adjacent medulla. So that's one of the features that one sees with these slightly enlarged adrenals in a patient with PPNAD, as it's called. This is a higher view showing the cells, and they should remind you of the zona reticularis cells within the adrenal, that one has the lipofuscin pigment that's seen in that inner zone, the sex steroid-producing zone of the adrenal. Nevertheless, it's glucocorticoids and Cushing's that these patients have, and it can be very difficult for the endocrinologist to diagnose. And sometimes, in terms of subtle pathologic changes, you can have these myelolipomatous changes with adipose tissue. But these are not myelolipomas as such, but early stages of the development of such an entity. The differential diagnosis, of course, if you see one of these grossly, would be black adenoma, metastatic melanoma, or oncocytoma of the adrenal cortex. Patients often have pituitary tumors, as we see in the stellar persica here. They're more commonly prolactin, growth hormone producing tumors, but prolactin in this setting is the second most common lesion. And then the lentiginous that they have in different sites, and these myxomas as such on the skin, on the breast, all the myxoid area beneath the epidermis, would be a lesion that was excised from the patient with Carcinoma complex. And then the really life-threatening condition, in addition to Cushing, is the myxomas. And in the pathology lab, we know that we usually see patients with myxoma. It's usually a solitary lesion, but in this case, and in cases of Carcinoma complex, there are usually multiple myxomas present within the heart, and the histology of these would be very similar to myxomas that one would see in other sites. And from the early description that Dr. Carney made in the 1970s and 80s, he's collaborated with many individuals, Dr. Stratakis at the NIH, and they've really located two loci of abnormalities in kinase complex. Chromosome 17, in which the protein kinase A is affected, and then chromosome 2P, and that's been labeled by Dr. Stratakis as kinase locus. We often tease him and say, "You're the only pathologist we know that has a chromosome locus named after you around." But these are things, and then there are animal models in which with protein kinase mutation that develop many of the problems with the adrenals and other lesions of myxoma as in kinase. A couple of other things to touch on briefly before we end is von Hippel-Lindau. Most of us from medical school and the practice of pathology are usually thinking of renal cell carcinomas and hemangioblastomas when we're thinking of von Hippel-Lindau. But for the endocrine pathologist who may sometimes be too narrowly focused, he or she is thinking of chromocytomas and islet cell tumors are some of the things. So again, as in MEN2A and 2B, pheochromocytomas are often bilateral in these patients. So if you have a patient whose specimen comes into the pathology lab, you see pheochromocytomas involving both adrenals, it definitely doesn't have to be just MEN2A or 2B. It could certainly be von Hippel-Lindau or neurofibromatosis that we'll touch on shortly as one of the things, and then islet cell tumors. This is again another autosomal dominant disease, chromosome 3P, and another tumor suppressor gene that one sees. And the intriguing thing about the pancreatic lesions is that they're usually composed of clear cells. And so looking under the microscope, we can recognize these very readily, the clear cells, and if one has a lot of small nests of these cells, one can suspect that you're dealing with von Hippel-Lindau's disease. The duodenal somatostatinomas is a question that we frequently ask residents about, and usually appears in the board question when they're taking the exams as such. But the pancreatic lesions one sees in a fair number of cases here would be such an example that we have the clear cells that dominating in the picture, and then higher up shows the cells that almost look like vacuolated macrophage type cytoplasm in these cells, but nuclear are bigger, and they're similar to the cells that are in the upper right-hand corner that are slightly different. So a feature not only in MEN1, in which you see multiple lesions in the pancreas of the patient, but in von Hippel-Lindau, again, we're going to have multiple lesions in the pancreas of these patients affecting the endocrine cells. What about neurofibromatosis, type 1? Again, a spectrum of diseases, and we usually think of the abnormalities of the nerve sheath lesions, but pheochromocytomas that are seen in these patients, somatostatin-producing neuroendocrine tumors are also seen in these patients. They can have what's pretty uncommon, medullary thyroid carcinomas and hypothalamic gliomas as such. So to give you a broad perspective of these abnormalities affecting the adrenal, in this slide here, you can see MEN2A, 2B. We often have pheochromocytomas, but in half of the patients. Neurofibromatosis 1, also with bilateral disease, and a smaller percentage of patients with von Hippel-Lindau disease. Familial paragangliomas we'll revisit this afternoon when we talk about some of the cases. The intriguing thing in the last 8 to 10 years is that there is specific mutations in the familial cases of the succinate dehydrogenase gene, and this affects a smaller number of patients. than with the other familial disease for pheochromocytomas, but they usually have extra-adrenal diseases as such. So in summarizing some of the highlights of the points that we really wanted to make, we have looked at NEN1, 2A, 2B, and these are things that, as a pathologist, these are the things that we're going to see most commonly in the surgical pathology lab, and we can certainly help our clinical colleagues by at least raising that specter if the diagnosis has not been made in that family before, with medullary thyroid carcinoma, C-cell hyperplasia, with pheochromocytomas, seeing medullary hyperplasias as such. When we're looking at tissues for patients with von Hippel-Lindau disease, this is taking up the kidneys for renal disease, then certainly the adrenals often comes up with kidneys, and we have an opportunity to look at these for pheochromocytomas or hyperplasia. And of course, the pancreas, we have the endocrine tumors that are seen. With neurofibromatosis, we have the pheochromocytomas as well, again, somatostatinomas, and rarely medullary thyroid carcinomas. And cardiac complex, even though we're not going to see too many of those in terms of long period of practice, it's such a fascinating array of different lesions that come together forming this, and the genetics of this has been partially worked out so far, and a lot more, I'm sure, will be coming over the next few years. So that's my last slide, and if you have questions or comments, I'll be glad to take them this time.